Then volatile quick facts will be covered. High yield topics for all the subjects will be taken now. And most important and most frequently expected topics will also be covered through this series so that you can benefit in your university exams and apart from that for your NEET PGs and FMG as well. Then for today's class, we're going to cover hormones today. So all the short question answers, for example, the parts of pituitary gland, discuss the various hormones like growth hormones and insulin, important hormones, thyroid hormones, then the actions and abnormalities associated with growth hormones and thyroid hormone and insulin, the important hormones, then the process of synthesis of the various hormones, then their actions, that what are the actions they're bringing about, and then the mechanism of release of insulin. So these are all the important questions that you get asked. They're important as well as they're also very frequently asked. Obviously, since they're important, they're frequently asked. Then, as we know that we have three different subscription plans at Oracle. The basic plan, which is for 3 months and comes at 15,000. Then you have the standard plan, which is for 6 months and it will cost you 30,000. And then the mentorship plan, which is for the entire year, that is for 12 months and comes at 50,000. So in the mentorship plan, you have the facility of availing the notes and you also get one-to-one personalized guidance. Then apart from that, if you want to avail extra discount, you can use my promo code as displayed here on the screen. And then it will give you 20% additional discount. Then talking about the core features of Oracle, here at Oracle, we have live classes to elevate your learning experience. Then we also provide you with recorded lectures so that you have the facility of accessing the lectures anytime, anywhere as per your convenience. Then we also provide you with notes and MCQs based on the latest CBME syllabus so that apart from just learning, you can also assess your knowledge, okay? Then a very unique feature of Oracle is that here at Oracle, we provide you with personalized counseling sessions. So apart from the academic support, we are also willing to help you with the non-academic support. So if there's anything apart from academics that you want to discuss or that is bothering you, you can anytime feel free to book a slot with us and we'll be more than glad to help you. So with this little introduction, let's start today's class that is on hormones. Okay. So as we all know that hormones, they are chemical messengers and these hormones, they are very important in our body since they are involved in integration and coordination of various actions in the body. Okay. So from controlling your growth to your mood, everything is coordinated by hormones that are present in the body. So they're basically chemical messengers. So today we're going to talk about hormones. So without wasting much time, let's delve into the world of hormones.
Ma'am, can you maximize the screen? This one.
Maximize from where? There's no option for full screen.
Yesterday you have rotated it, ma'am, so it became max.
Okay.
Yeah.
Like this?
Yes, correct, ma'am. Right. Looking big, ma'am. No. Now looking good, ma'am.
Is it fine now?
Yes, ma'am. Yes, ma'am. Is it good? Yes, it is, ma'am.
Oh. Okay.
Okay.
Should I start then?
Yes, ma'am. Yes, please.
Okay. So, back to our. Okay, so let's begin with the most important glands in the body, that is pituitary. So as we all know, there was some connection error, so I'll repeat myself. So we're talking about hormones today. Hormones are chemical messengers in the body which are secreted by various endocrine glands that are present at different locations in the body. Okay, so these hormones are responsible for bringing about coordination and integration of various actions taking place in the body. They are responsible from controlling your growth to your mood. So they're very important chemical messengers, these hormones. So we're going to talk about hormones today. So the first gland we're going to talk about is pituitary, a very important gland in a body is pituitary gland. Okay, so it is known as the master gland. So you know how important it must be since it's called the master gland of the body. So the secretions of the pituitary gland, they are in turn controlled by hypothalamus. Okay, now your hypothalamus, it is producing releasing factors as well as inhibitory factors. Okay, so if I draw it in the form of a flow chart, it's going to look like you have your hypothalamus. So your hypothalamus, it is secreting releasing factors, which is going to stimulate your pituitary. And also your hypothalamus is secreting inhibitory factors, which is going to inhibit your pituitary gland. Okay, so the secretions of the pituitary gland, they are in turn controlled by what? By the hypothalamus. And hypothalamus is both secreting releasing factors as well as inhibitory factors. Now, your hypothalamus on stimulation, it is going to produce stimulatory hormones. Then these stimulatory hormones, they are going to stimulate the target endocrine glands. Okay, so they stimulate target endocrine glands, and then these glands, they secrete the various corresponding hormones. Okay, so that was a little flow chart to explain how it's working. So your hypothalamus, it is going to stimulate or inhibit pituitary gland. Depending upon that, your pituitary gland is going to stimulate the various target endocrine glands, and then endocrine glands are going to secrete their various specific hormones. So that was about a little introduction to the pituitary gland. Where is the pituitary gland located and all? We'll be talking about in anatomy, but a little introduction since I'm giving. So it is located in a cavity known as sella turcica in the sphenoid bone. Okay. So moving ahead, now your pituitary is divided into anterior pituitary and posterior pituitary. Here, I've zoomed in, as you can see here in the diagram. So this is your pituitary gland. Here, this pituitary gland, and then they've zoomed this gland, and you can see it is divided into a posterior pituitary and a larger anterior pituitary. So now let's have a look at the various hormones that are secreted. So the anterior pituitary is producing the following hormones, that is the growth hormone, your prolactin, your thyroid stimulating hormone, TSH, your adrenocorticotropic hormone, ACTH, follicular stimulating hormone, and luteinizing hormone. So these are the hormones that are produced by the anterior pituitary. Now, anterior pituitary has basically two types of cells, acidophilic cells and basophilic cells. The acidophilic cells, they are producing growth hormone and prolactin. Now, whatever hormones are left, they'll automatically fall into the basophilic cells. That is your TSH, ACTH, FSH, and LH. So they are produced from the basophilic cells. So you only have to remember one of it, that is your anterior pituitary has two types of cells, acidophilic cells and basophilic cells. The acidophilic cells, they produce growth hormone and prolactin. And growth hormone and prolactin are also known as twin hormones. And your basophilic cells, they are producing TSH, ACTH, FSH, and LH. Now, apart from these two cells, it also has a special cell known as corticotropes. Okay, so anterior pituitary, apart from having the acidophilic and basophilic cells, it also has a special cell known as corticotropes. Now, these corticotropes, they produce a precursor molecule known as pro-opiomelanocortin, that is POMC. Now, from this POMC, three substances are derived, that is endorphin, melanocyte stimulating hormone, and ACTH. So, your endorphin, it is considered as an endogenous painkiller. Now, what do you mean by an endogenous painkiller? So, your endorphins, these are peptides that are produced in the brain and they block the perception of pain and increase the feeling of well-being. Okay. So, therefore, you can consider them as endogenous painkillers. They are produced when there is some physical activity or exercise taking place in the body, and they prevent, inhibit pain, muscle cramps, and relieve stress. So, therefore, because of these features, it is considered as an endogenous painkiller. Then, your melanocyte stimulating hormone, the name itself is very indicative that they are stimulating what? The melanocytes. And the melanocytes, they are producing melanin, okay? And then you have ACTH, that is adrenocorticotropic hormone. It regulates cortisol secretion and release, okay? So that was about anterior pituitary. So your anterior pituitary is producing six major hormones. We've named them. Then we have said that it has three different types of cells, acidophilic, basophilic, and a special type of cell known as corticotropes. From these corticotropes, a precursor molecule known as POMC is produced, and from these POMC, three different substances are derived. That is your endorphin, melanocyte stimulating hormone, and ACTH. Now, moving on to posterior pituitary. Now, your posterior pituitary does not produce any hormone, okay? So basically, it is involved in the storage and release of two hormones, that is vasopressin and oxytocin. Okay, so they are produced in the hypothalamus, your vasopressin and oxytocin. It is produced in the hypothalamus and then it is stored and released from the posterior pituitary. Okay, so remember this, very important, that your posterior pituitary as such is not producing any hormone. It is only involved in the storage and release of vasopressin and oxytocin. Now, the storage bodies of these hormones are called as herring bodies. So that was about posterior pituitary. Now we'll discuss in detail about the growth hormone since it is very important. So as I told you that your prolactin and growth hormone, they are considered as twin hormones. Now why are they considered as twin hormones? Firstly, because they have a common source. Secondly, they have similar receptors. And thirdly, because they have similar change in levels with respect to each other. Okay. So both of them, as we spoke earlier also, that they are produced from acidophilic cells. So your growth hormone and your prolactin, they are twin hormones. They are produced from acidophilic cells. Now, the level of growth hormone is maximum in adolescent and it is lowest in old age. And it is also very obvious because during your growing years, during adolescence, that is when you need growth hormone because the body is growing. So that is when you require the growth hormones. And during old age, there's no growth. So the level of growth hormone is lowest in old age. And before we move to the actions of growth hormone, another point that you should remember is that they act through JAK-STAT pathway. That is Jonas kinase pathway. Okay, sometimes you might get this as an MCQ in your PG exams. So that is they act to JAK-STAT pathway. That is Jonas kinase pathway. Okay. Now moving on to the actions of growth hormone. So your growth hormone, firstly, if we talk about the factors that are going to increase the synthesis of growth hormone. So first factor that increase growth hormone. So the most important factor is hypoglycemia. That is low blood glucose level. low blood glucose. So all the factors that are decreasing the blood glucose in the body, they are causing hypoglycemia. All those factors, they are going to increase the level of growth hormone in your body. So for example, fasting, starvation, exercise, stress, all of this is going to cause hypoglycemia. So all these factors, they are going to increase growth hormone in the body, and the reverse is going to happen. That is, all the factors that cause hyperglycemia, they are going to decrease the growth hormone in your body. So your growth hormone is a hyperglycemic or a diabetogenic hormone. Okay. So growth hormone is a hyperglycemic or diabetogenic. What is meant by this? I'm going to explain diabetogenic hormone. Okay. But before that, let's talk about the actions of growth hormone. Firstly, the direct action of growth hormone, that is the growth hormone itself, it acts as an anti-insulin. Okay, so it is going to have actions which are opposite to that of insulin. Okay, so it is working in contrast to insulin. So your insulin, it is responsible for decreasing the blood glucose level. Okay, it increases the uptake of glucose by the cells. Since we are saying that growth hormone is anti-insulin like in action, so rather than decreasing, what is it going to do? It is going to increase the blood glucose level. So we say causes hyperglycemia. And we also now know that your insulin was inhibiting hormone sensitive lipase. So it was inhibiting lipolysis. So your growth hormone, it is going to enhance or favor lipolysis. So these two, that is hyperglycemia and lipolysis, these are the anti-insulin like actions caused directly by the growth hormone itself. Okay. If you remember, I had told you that assume this is an adipocyte, and what was happening? Your triacylglycerol was broken down into free fatty acid plus glycerol via hormone sensitive lipase. Now this hormone sensitive lipase, it was being inhibited by insulin. So if insulin is going to inhibit this hormone sensitive lipase, that means lipolysis is not taking place, hydrolysis of tag is not taking place. And glucagon was activating this hormone sensitive lipase. And since we are saying that growth hormone is acting in contrast to insulin, so insulin, as we can see, it is inhibiting lipolysis. So your growth hormone, it is going to enhance or favor lipolysis. Okay. So that was about the direct actions of growth hormone. Now moving on to the indirect action of growth hormone. The indirect action of growth hormone, it is mediated by somatomedins. Okay, now what are somatomedins? These somatomedins, they are produced exclusively by the liver, and they are produced on stimulation by the growth hormone. So growth hormone, it is going to stimulate the secretion of somatomedins from the liver. And what is a somatomedin? It is also known as insulin-like growth factor. It is a mitogen. And this somatomedin, it is known as insulin-like growth factor. Why? Because it is similar in molecular structure, similar in molecular structure to insulin. Okay. And also, it is growth hormone stimulates somatomedin release, secretion and release from liver. Okay, so we can say in short that the mitogenic effect of growth hormone, it is mediated through somatomedin. So your somatomedin, it is acting as a mitogen. Okay, so the direct action of growth hormone, it is anti-insulin like, and the indirect action of growth hormone, it is mediated through somatomedin, and it is insulin like. So when it is insulin-like, it is going to be anti-lipolysis. Okay, so it is going to inhibit or it is not going to favor lipolysis. Now talking about action of growth hormone on bone growth. So on bone growth, so growth hormone, it has both direct and indirect action. It is going to convert free chondrocytes to mature chondrocytes. Okay, and then the further bone growth, it is mediated by somatomedins. So that was about growth hormones, the actions of growth hormone. Now talking about the abnormalities of growth hormone. So the various disorders associated with it in children, if there's excess growth hormone, it is going to lead to gigantism, as you can see here in the picture. So excess of growth hormone, it is going to cause gigantism. So there is excessive elongation of the long bones of the body. And in adults, it is going to cause acromegaly. So excess of growth hormone in adults, it leads to acromegaly. So in acromegaly, you have large hands, prominent chin and jaw. These are the manifestations of acromegaly. And deficiency of growth hormone, it is going to cause dwarfism. Now there is something known as Laren's dwarfism. Okay, in this, what is happening? Your growth hormone levels are normal, but this is due to mutation of growth hormone receptors. Okay, so what is happening in Laren's dwarfism? Your growth hormone level is normal, but your somatomedins medins is low. This is because there is mutation in the growth hormone receptors. Okay, so your growth hormone, it is not able to cause the stimulation and the secretion of somatomedins. Okay, and there is mutation in growth hormone receptors, which leads to Laren's dwarfism, although there is normal level of growth hormone in the body. So with this, we come to the end of pituitary. I'll recapitulate. So we started with the pituitary gland. We said that it is the master gland of the body, and its secretion are in turn controlled by the hypothalamus. The hypothalamus is secreting releasing factors which stimulate the pituitary, and inhibitory factors which is going to inhibit the pituitary. Now the pituitary is divided into anterior pituitary and posterior pituitary. The anterior pituitary, it is producing 6 different hormones, namely growth hormone, prolactin, TSH, ACTH, FSH, and LH. And your anterior pituitary has 3 different types of cells: acidophilic cells, basophilic cells, and a special cell known as corticotropes. Your acidophilic cells for producing growth hormone and prolactin, and your corticotropes were producing a precursor molecule from which were derived endorphin, melanocytes, and ACTH. Endorphins, I said, they are endogenous painkillers because they block the perception of pain. They are peptides produced by the brain. And your melanocytes, they are melanocyte stimulating hormones. They are stimulating melanocytes, and melanocytes are responsible for the secretion of melanin. And your ACTH, it is regulating the release of cortisol in the body. Now, talking about the posterior pituitary, it was not producing any hormone. It was involved with the storage and release of vasopressin and oxytocin. This vasopressin and oxytocin, it was basically being produced by the hypothalamus, and the storage bodies of these two hormones are called herring bodies. Now, moving on to the growth hormones. So we discussed growth hormone, that prolactin and growth hormone are twin hormones, and we discussed the reason why they're known as twin hormones, because they have a common source, similar receptors, and similar change in levels with respect to each other. Then we spoke about the actions of growth hormone, which are very important. So talking about the action of growth hormones, firstly, it has direct actions. So the direct action of growth hormone is anti-insulin-like. So when you remember it is anti-insulin-like, so it becomes very easy. Your insulin, what does it do? It causes hypoglycemia. It decreases the blood glucose level. But we are saying growth hormone is anti-insulin-like. So your growth hormone is going to increase the blood glucose level. So it causes hyperglycemia. And also your insulin, it was inhibiting lipolysis. So your growth hormone, it is going to favor lipolysis. So as anti-insulin-like actions, it causes what? Hyperglycemia and lipolysis. So that is the direct action of growth hormone. Now, indirect action of growth hormone, it is mediated through somatomedins. Now, what are somatomedins? Somatomedins are mitogens which are produced exclusively by the liver on upon stimulation by the growth hormone. So your growth hormone, it is going to stimulate the liver to produce somatomedins. Now these somatomedins are also known as insulin-like growth factors. Why? Because they are similar in molecular structure to insulin. Now, as indirect actions which are mediated through somatomedins, so your growth hormone, it is going to have insulin-like action. So it includes anti-lipolysis. Now talking about the action of growth hormone on bones. So growth hormone was having both direct and indirect effect on the bone. It was converting the pre-chondrocytes into mature chondrocytes. Then talking about the abnormalities, if you have excess growth hormone in children, it causes gigantism. In adults, it causes acromegaly, and deficiency of growth hormone is going to cause dwarfism. Now there is Laren's dwarfism. The catch point here is that although the growth hormone level is normal here, but what is defective here? There is mutation in growth hormone receptors, okay? So which leads to dwarfism. So with this, we come to the end of pituitary gland. Now talking about thyroid gland. Another very important gland with very important secretions, that is thyroid hormones, okay? So talking about the thyroid gland, your thyroid gland, it has uh, follicular cells and parafollicular cells. So if we talk about the cells of thyroid gland, okay, so talking about the cells of thyroid gland, it has follicular cells, which produce the thyroid hormones, that is T3 and T4, and you have parafollicular cells, which produce calcitonin. Okay, I'll briefly describe the structure of thyroid gland, although it is not important here in biochemistry. You must be studying this in physiology. But your thyroid gland, it has follicles, okay? Something like this. Hmm. Pen is not working. Okay. Yeah. Okay, it's working now. Okay, so your thyroid gland, it has follicles like this, and these follicles, they are lined by follicular cells. So these are your follicular cells. Okay. And your parafollicular cells, they are present here. In between these follicles, you have these parafollicular cells. So these are your parafollicular cells, which produce calcitonin, and these are your follicular cells. The details of this you're going to study in physiology. So just know for now in biochemistry that you have a thyroid gland. It has follicles. The follicles are lined by follicular cells, and in between the follicles you have parafollicular cells. Now these follicular cells, they are going to produce T3 and T4, that is the thyroid hormone. Now the requirements for the production of your thyroid hormone. So what all do you need for the production of thyroid hormone? So you need iodide. Now what is this iodide? Where is this coming from? So it is the reduced form of iodine that is obtained from dietary sources. So whatever iodine you are getting from dietary sources, it is reduced to form iodide. So the reduced form of iodine from the dietary sources, that is your iodide. And then what else do you need? You need tyrosine. Where is this tyrosine coming from? These tyrosine residues are coming from thyroglobulin. And what is thyroglobulin? It is a glycoprotein which is again produced by follicular cells. So this thyroglobulin, it is a glycoprotein produced by follicular cells. Okay. So the two requirements for the production of thyroid hormones, it is your iodide and your tyrosine. Tyrosine residues, they are coming from thyroglobulin. And what is thyroglobulin? It is a glycoprotein produced by the follicular cells. Now let's talk about the process of synthesis of thyroid hormone. Very important. So for the process of synthesis, I'm going to draw a small diagram. Mm, Okay, maybe here. So it says, if you consider, like, this is your follicular cell. Okay, this is your follicular cell. This is a blood vessel. Okay. So for the synthesis, it is saying a sodium iodide symporter. It is present on the basolateral side of the follicular cells. So before we start with that, let's talk about what is basolateral side and what is the apical end. So the basolateral end is that end which is close to the blood vessel, and the apical end is that end which is away from the blood vessel. So if you talk here in this diagram that I've drawn, see, I've drawn this follicular cell and I've drawn a blood vessel. Now this end which is close to the blood vessel, it is considered as the basolateral end. So this is going to be the basolateral end. As you can see, this end of the follicular cell, it is close to the blood vessel. So this is the basolateral end, and the other end, which is away from the blood vessel, it is considered as the apical end. Okay. Now you understand what is the basolateral end, what is the apical end. So now you will be able to understand where this sodium iodide symporter is present. Now another term before I begin is the symporter. That what is a symporter? Okay. So a symporter is that protein that moves two molecules in the same direction across a membrane. So that is your symporter. Okay. So symporter is a protein that is moving two molecules across a membrane in the same direction. So that is a symporter. And another term is antipode. You should know this also. Now, what is an antipode? Your antipode is a protein which is going to move two molecules across a membrane in opposite directions. So, sympode in the same direction, antipode in opposite directions. Okay. Now, let's talk about the process of synthesis of thyroid hormones. Now that you know these terminologies, you'll be able to understand the process. So, it says that present on the basolateral side of the follicular cells, you have sodium iodide symporter. So I'm going to draw that now. Okay, I'm going to draw this in green. So this is the basolateral side and this is a follicular cell. So on the basolateral side, you have this sodium iodide symporter. Okay, now since this is a symporter, it is going to transport sodium and iodine from the blood vessel. So sodium and iodide from the blood vessel, it is going to move inside the follicular cell. Okay. It is taking place, the transport is taking place in the same direction since it is a symporter. So through this symporter, your sodium and iodide ions, they are transported from the blood vessel to the follicular cells, and this is taking place via secondary active transport. Now what happens? Now before that, it says if there is excess of iodide inside the follicular cells through the symporter, then the synthesis of thyroid hormone is inhibited, and this is known as Wolff-Chaikoff effect. So what is Wolff-Chaikoff effect? That is if excess levels of iodide come in the follicular cells via the symporter, then the thyroid hormone synthesis is inhibited, and this is known as Wolff-Chaikoff effect. Now let's see what is happening. So you have excess of iodide coming inside in the follicular cells. Now this iodide, since it is in the reduced state, it needs to be flushed out of the follicular cells. Now this flushing out of the iodide from the follicular cells, it is taking place by a chloride iodide antiport. Okay, I am going to draw that in pink here. Okay, so on the basolateral side, I'm going to repeat myself. This is a follicular cell. On the basolateral end of the follicular cells, you had a sodium iodide symporter. So because of this symporter, sodium and iodide, they're going to enter the follicular cells. Now what happens? Since this iodide is in reduced state, it needs to be flushed out of the follicular cells. So on the apical end of the follicular cell, you have chloride iodide antiport. So your iodide is going to move out of the follicular cells, and to balance that iodide moving out, what is happening? Your chloride is moving in. So chloride is moving in and your iodide is moving out of the follicular cells. Okay. Now your chloride is out from the follicular cells. Now what is happening? It is going to be acted upon by a hormone known as thyroid peroxidase. So this iodide, I don't have space here. Okay. Okay. If you can see this arrow, so you can see your iodide is moving out of the follicular cell. I have drawn this arrow, so I'm going to carry the reactions here now. So your now iodide, it is in the reduced state. Now it is going to be acted upon by an enzyme known as TPO, that is thyroid peroxidase, and it is going to convert this into oxidized state. Okay. Now what happens? This I2, it is incorporated into tyrosine or from the thyroglobulin, and this is known as organification of iodine. Okay, so this process is known as organification of iodine. So what is happening in this into the tyrosine of thyroglobulin? Okay, now what is going to happen? Coupling reactions are going to take place. Now, because of coupling reaction, what is happening? जो monoiodotyrosine is being formed. That is, you have oxidized iodine. It combines with tyrosine. So when one iodine combines with tyrosine, it forms monoiodo. Okay, since there is one iodine, monoiodotyrosine. Now, what is diiodotyrosine? That is when MIT plus MIT, two MITs, they couple together, they form diiodotyrosine. Now, when one MIT couples with DIT, that is diiodotyrosine, you end up with what? T3. And when DIT couples with, that is diiodotyrosine, it couples with MIT, that is monoiodotyrosine, you end up with reverse T3, that is the inactive form. Okay. And when two DITs they couple together, you end up with T4, that is known as thyroxine. Okay, that is tetraiodothyronine. And T3 is triiodothyronine. So that was about the synthesis of thyroid hormone. And also one important point regarding the synthesis is that your chloride and iodide antiport, it is also known as pendrin. Okay, so any mutations in this pendrin, it will lead to what is known as pendrid syndrome. Okay, and this pendrid syndrome, the manifestations are goiter and sensory neural hearing loss. Okay, so in goiter, there is enlargement of the thyroid gland. So before I move forward, I'm going to repeat this. That is the process of synthesis of thyroid hormone. It's a little complicated, so pay attention. I'm going to repeat this. Firstly, I introduced you to the thyroid gland, that how the thyroid gland, it has follicles. The follicles are surrounded by follicular cells. In between the follicles, you have another type of cells known as parafollicular cells, as you can see here in this diagram that I've drawn. Your follicular cells, they were responsible for producing T3 and T4, and your parafollicular cells, they were producing calcitonin. Having said that, we spoke about the requirements for the production of thyroid hormone. So you require iodide, which is the reduced form of iodine that you're getting from dietary sources, and you require tyrosine. These tyrosine residues are present in thyroglobulin, which is a glycoprotein also produced from follicular cells. Now talking about the process of synthesis of thyroid hormone. So you have the follicular cell, the basolateral end of the follicular cell, that is, basolateral end is that end of the follicular cell which is close to the blood vessel, and the apical end is that end of the follicular cell which is away from the blood vessel. So on the basolateral end you have sodium iodide sympater, and on the apical end chloride iodide antipode. Cause the movement of two molecules across a plasma membrane in the same direction. In antipode, they're going to cause the movement of two molecules in opposite direction across the plasma membrane. So with that basic knowledge, I explained you the process of synthesis of thyroid hormone, that how from the blood vessels your iodide and sodium is going to move inside the follicular cells. Now, once inside the follicular cells, the iodide is going to move out of the follicular cells, and to balance that moving out of the iodide, chloride is going to move in. Now, this iodide, once outside the follicular cells, from its reduced state, it is getting converted into its oxidized state, iodine, and this is brought about by the action of an enzyme known as thyroid peroxidase. Now, what happens? Organification of iodine is going to take place. That is, your iodine, it is going to be incorporated into tyrosine of the thyroglobulin, and then you end up with what? You end up with MIT, that is known as monoiodotyrosine. So these are coupling reactions. You see, to oxidize iodine, it is going to be incorporated into tyrosine, and you end up with monoiodotyrosine. Now, this monoiodotyrosine, if two of them combine together, they form diiodotyrosine. And if one monoiodo combines with one diiodotyrosine, you end up with T3. And if one DIT combines with one MIT, you end up with reverse T3. And if two DITs combine together, you end up with T4. So you see your T3, T4, that is the thyroid hormones, they have been synthesized. So that was about the synthesis of thyroid hormone. Now, one of the clinicals that we studied was that I told you that your chloride iodine antipode, it is also known as pendrin, and a mutation in pendrin, that is any mutation in this antipode, leads to what is known as Penred syndrome. Okay, so that was one thing. Now, another thing, your thyroid peroxidase, which was converting your reduced form of iodine into oxidized iodine. If this is blocked, this enzyme is blocked, what will happen? You will not have oxidized iodine. And if you do not have oxidized iodine, what will happen? Your thyroid hormone synthesis will be affected. Okay, so if you give blockers, that is thyroid peroxidase blockers, what are you trying to do? You're trying to decrease the thyroid hormone synthesis. So your TPO blockers, that is thyroid peroxidase blockers, they are anti-thyroid drugs. Okay, so now moving ahead, let's talk about the actions of thyroid hormone. So the most important action of thyroid hormone, that is, it increases the BMR. What is BMR? That is basal metabolic rate. So it increases the basal metabolic rate. How? By increasing the oxygen consumption. That is, it increases the use of cellular oxygen. So it increases the use of cellular oxygen. Okay. Now, Another thing, when BMR increases, your cellular metabolism of carbohydrate, protein, and lipid, that also increases. So it is a major catabolic hormone. It is increasing what? It is increasing lipolysis, it is increasing proteolysis, and it is also increasing glycogenolysis. That is the breakdown of glycogen. So when your glycogen is going to break down, it is going to give glucose. Therefore, it is considered as hyperglycemic as it is breaking down glycogen. Now, it's another effect on electron transport chain. That is, it is a physiological uncouplers. Now, what are uncouplers? Uncouplers are those substances which cause hole in the inner mitochondrial membrane. So, the proton gradient is going to be dissipated. So, what is happening? There is no phosphorylation taking place. No ATP is being generated. So, we all know that in electron transport chain, what is electron transport chain? It was coupling of oxidation with phosphorylation. But here, this thyroid hormones, they act as uncouplers. So what are they going to do? Your oxidation is going to take place. That is, your electrons are going to jump from one complex to the other. So jumping of electrons is taking place. That is, oxidation is taking place. But what is not taking place? The phosphorylation is not taking place. ATP is not being generated. Since these uncouplers, they're going to form holes in the inner mitochondrial membrane. So as a result of which, the energy released during oxidation that was supposed to generate ATP, it is now going to generate heat. So this is the thermogenic action of your thyroid hormone. That is, it increases the body heat. It has thermogenic action. So as a result of which, in patients with hypothyroidism, what is hypothyroidism? That is, they do not have enough or they have less levels of thyroid in the body, thyroid hormone in the body. So what is happening? This thermogenic action of thyroid is going to be missing. So they are going to be cold intolerant. They'll not be able to tolerate cold. And the opposite is going to be seen in patients with hyperthyroidism. That is, they have excess levels of thyroid hormone in the body. So this thermogenic action of thyroid is going to be more. So they're going to be heat intolerant. Okay. So patients with hypothyroidism, they're going to be cold intolerant, and patients with hyperthyroidism, they're going to be heat intolerant. So we've discussed the catabolic nature of thyroid hormone. We've discussed its action of BMR, then its action of electron transport chain, then talking about the developmental role. So your thyroid hormone, it is involved in development of brain and bone. So the growth of brain is dependent on thyroid hormone since it increases the myelination in central nervous system, and also it is involved in growth of the bones. So in cases of congenital hypothyroidism, that is when you have lower levels of thyroid, what is going to happen? It is going to be manifested as mental retardation and stunted growth. Then apart from that, the effect of thyroid hormone in the heart, it is going to increase the heart rate and myocardial contractility. How? Because it is going to increase the responsiveness of heart to circulating catecholamines. So what are your catecholamines? Epinephrine and norepinephrine. So your epinephrine and norepinephrine, they increase the heart rate and myocardial contractility. So your thyroid hormone, it is going to increase the responsiveness of the heart to catecholamines level. So in turn, it is going to increase the heart rate and myocardial contractility. So with this, we come to the end of thyroid hormone. So we've discussed the synthesis and we've discussed the action of thyroid hormone, very important, that will increases BMR by increasing the use of cellular consumption of oxygen. So by increasing the cellular consumption, by increasing the BMR, it is going to increase cellular metabolism of carbohydrate, lipids, and proteins. So it causes lipolysis, proteolysis, and glycogenolysis. Then it acts as a physiological uncoupler. So it has thermogenic effect. Then we spoke about its developmental role. It is involved in the growth of brain and bone. And then also it increases heart rate and myocardial contractility. Now, moving ahead, let's talk about insulin, another very important hormone. So, your pancreas, it is secreted from the pancreas. Your pancreas, they are a composite gland, okay? So, your pancreas, they are a composite. That is, it has both exocrine and endocrine part. Now, the endocrine part of the pancreas, majorly, it is the tail end, the tail part of the pancreas constitute the endocrine part of the pancreas. So they have different isolated groups of cells which look like islands. So they're known as islets of Langerhans. Okay. So the tail of the pancreas, it has a collection of isolated cells which look like islands. Therefore, it is known as islets of Langerhans. Now, these islets of Langerhans, they have different cells. They have alpha cells or A cells which produce glucagon. They have beta cells which produce insulin, amylin, and C-peptide. Then they also have delta cells which produce somatostatin and F cells which produce pancreatic polypeptide. So your islets of Langerhans, they have alpha cells, they have beta cells, they have delta cells, and they also have F cells. So your alpha cells, they produce glucagon. Your beta cells, they produce insulin majorly. They also produce amylin and C-peptide. And your F cells, they produce pancreatic polypeptide. Okay. So your insulin, it is, as we all know, it reduces blood glucose level. So amylin, it potentiates insulin action. So it is going to enhance or favor the action of insulin. And your C-peptide, it is considered as an endogenous insulin marker. What it means is that your C-peptide is formed when insulin is produced. So it is produced in the same equimolar proportion. Okay. That is in the 1:1 ratio. So your C-peptide and your insulin, it is produced in equimolar proportions. That is 1:1 ratio. So when your C-peptide is formed, your insulin is also formed. Now this C-peptide and insulin, they enter the blood at the same time and in equal amounts. But what happens is this C-peptide, it has no effect on blood glucose, but it stays in the blood longer as compared to the insulin. So it is easier to measure the C-peptide accurately. So therefore we say it acts as an endogenous insulin marker. So now you understand what is meant by your C-peptide acting as an endogenous insulin marker. That is, it is produced in equimolar proportions as the insulin. That is in the ratio 1:1. Both of them are produced in equimolar proportions and entering into blood. That is your C-peptide and insulin. They are entering into the blood at the same time and they are produced in the same proportion. But what happens is your C-peptide is going to stay in the blood for a longer time. So it is easier for you to measure the C-peptide more accurately. So therefore, it is considered as an endogenous insulin marker. Now we are going to talk about the mechanism of insulin release. Very important. Okay. So he says after a meal, the glucose level increases in the body, which increases the ATP. So the ATP is going to close the potassium channels, and because of this, the potassium level rises inside the cell, and this leads to opening of voltage sensitive calcium channels. So there is calcium influx. Let's understand this with the help of this diagram given here. So you can see when the glucose level increases, okay, so as you can see here, your glucose level is going to increase. Then what happens? And this diagram here, this is of the beta cells of the pancreas. Okay. Okay, so this diagram here is of the beta cell of the pancreas, and the beta cells of the pancreas, they have GLUT2 transporter. Okay, that is glucose transporter 2. Now, what is special about this GLUT2 transporter? That it is insulin independent glucose transporter. Now, obviously, it needs to be insulin independent, because if it depends transporter itself is going to depend on insulin, then glucose will never be able to enter the cell and there will be no secretion of insulin. Okay, so this GLUT2 here is insulin independent. The example of insulin dependent transporter is your GLUT4, which is present in skeletal muscle and adipose tissue. Okay, so that is GLUT4, which is insulin dependent. But here in the beta cells of the pancreas, you have GLUT2, which is insulin independent. So when the blood glucose increases, what happens? Glucose via the GLUT2 transporter in the beta cells, it is going to enter the beta cells. Now, once inside the beta cells, this glucose is acted upon by glucokinase and it forms glucose 6 phosphate. Now, this glucose 6 phosphate it is going to enter glycolysis and produce what? ATP. So the ATP increases. As ATP increases, what is going to happen? ATP sensitive potassium channels, they are closed. Now, this closing of polarization, there's accumulation of potassium inside the beta cells, and this leads to opening of voltage sensitive calcium channels, as you can see here. So this leads to calcium influx. Okay, now this calcium influx, it causes what? It causes the exocytosis of insulin containing granules. So what is that? That inside the beta cells, you have insulin stored in granules. Okay, so once there is calcium influx, this calcium influx, it is going to cause these vesicles, these granules, which are storing insulin to move to the plasma membrane, fuse with the plasma membrane and release insulin. Okay, so insulin is released, as you can see here. Okay, so this is how insulin is released. Now let's see what they have to say. So the four important steps in insulin release, there is glucose sensor, there is closure of ATP sensitive potassium channels, opening of voltage gated calcium channels, and exocytosis of insulin. So we've discussed all these points, that how it's going to take place. See, I'll repeat this once again. When there is excess glucose, what is going to happen? So glucose, it is going to enter the beta cells of the pancreas via these GLUT2 transporters. These GLUT2 transporters, they are insulin independent. Once inside the beta cell, this glucose is going to be acted upon by glucokinase and converted into glucose 6-phosphate. Now this glucose 6-phosphate enters glycolysis and produces ATP. So the ATP level increases, which causes what? It causes the closing of the potassium channels, and this leads to depolarization. This depolarization causes opening of voltage sensitive calcium channels, and this leads to influx of calcium. Now, this calcium, it is going to make the insulin containing granules to move plasma membrane, fuse with the plasma membrane and release insulin. So your insulin is released. Now, one important secretogogues. Okay, now what are secretogogues? Yeah. So your secretogag, it is a substance which promotes secretion of insulin. So substance substance which promotes insulin secretion. That is an insulin secretogags. Okay. So your sulfonylureas, what do? They close ATP sensitive potassium channels. So when potassium channels are closed, what was happening? Depolarization was taking place and calcium channels were being opened, and ultimately what was happening? Insulin release was taking place. So sulfonylureas, they are insulin secretogags. How? Because they close ATP sensitive potassium channels, causing release of insulin. Okay, so these are used in the treatment of diabetes. In diabetes, what do you have? You have less insulin, so you need more insulin. So you give insulin secretogags like sulfonylureas, which causes insulin release. So that is one of the clinical sulfonylureas. So remember, it is an insulin secretogag. Now, another thing is that you can also decrease the insulin release. How can you decrease that? You can decrease that by closing these potassium channels. Okay, by opening these potassium channels, you are increasing this insulin secretion. Now, if you close these potassium channels, you're going to decrease the insulin secretion. So for that, what are you going to give? Oxide. Okay, so they decrease insulin secretion. How? By closing potassium channels. So they can be used in the treatment of insulinomas. Okay, that is a tumor of the pancreas. Okay, so when there is a tumor in the pancreas, it leads to insulinoma. There is excess insulin being produced. So you want to decrease the secretion of insulin. So in the treatment of insulinomas, what can you give? You can give those substances which cause the closing of these potassium channels. For example, one of those substance being diazoxide. Okay, and on the other hand, for diabetes mellitus, you can give insulin secretagogues when you want to increase the secretion of insulin. Now, moving forward, talking about the actions of insulin. So, the most important action of insulin, as we all know, that is involved in uptake of glucose by the cells. Okay, so it increases uptake of glucose in the heart, skeletal muscles, and adipose tissue. So, your heart, skeletal muscle, and adipose tissues, they have GLUT4 transporters. Now, I'm going to draw the actions of insulin in a tabular form so that it is easy for you to memorize. So the metabolic pathways and the effect of insulin on those pathways. Okay. So on this side, I'm going to write about those pathways which are stimulated by insulin. And on this side, the pathways that are inhibited by insulin. So as I said, your insulin, it is going to decrease the glucose level. It causes uptake of glucose by the cells. So all the pathways that are going to decrease the glucose level, they are going to be stimulated by insulin. So like glycogenesis, that is formation of glycogen, lipogenesis, and glycolysis. So all these pathways which are going to decrease the blood glucose level, they are stimulated by insulin. On the other hand, the pathways which increase the blood glucose level, they are inhibited by insulin, like your glycogenolysis. That is breakdown of glycogen. So when your glycogen is going to break down, it is going to release glucose. So your glucose level, blood glucose level is going to increase. Therefore, this glycogenolysis, it is inhibited by insulin. Your gluconeogenesis, your gluconeogenesis is producing glucose from new carbohydrate, from non-carbohydrate sources. Okay, new glucose it is going to produce. So again, it is going to increase the blood glucose level. So your gluconeogenesis, it is inhibited by insulin. Lipolysis, again, it is inhibited by insulin. And ketogenesis, it is also inhibited by insulin. So these are the functions of insulin. So with this, we come to the end of the lecture. If you have any queries, you can ask. So it was an important lecture today. So we've discussed pituitary, we've discussed growth hormone, the important hormone. Then we spoke about thyroid hormone, the synthesis and its function, and then insulin, again very important, the action of insulin and its process of synthesis and secretion. Okay, so thanks for watching. With this, we come to the end of the lecture. See you in the next class.